This is Walter Kemp. This is ischemic heart disease. This is going to be part 1. This is going to be just general features and stuff. There'll be 5 lectures on ischemic heart disease. So this is actually not the title, of course. This is my first introductory thing. This is actually at a rest area in Montana. This is really cool. There's like a double rainbow behind it. This is the one that started to fade already at this point, but there's actually a double. So, like I said, this is ischemic heart disease. This is 1 of 5. There are 2 websites I share. Ian Dr. Hughes put questions up for the USMLE Twitter, which I am really going to start back going. And like I said, I'm a friends pathologist, but I have a strong interest in general and organ pathology. I like to believe that I know a broad range of stuff, a broad range of things about a large number of topics through forensics and stuff like that, and through my interest. And I really enjoy teaching medical students. And heart is my favorite area, actually. So here are my disclaimers. Please pause, look at them, make sure they do not apply to you. I want to teach you pathology, but if you're not appropriate to be viewing the video, then stop. Same thing. Third disclaimer is right there. Same thing. And then the second part is this: if you're interested in my teaching style, just view my introductory presentation. I'll go through some of the things I've learned and some of the reasons why I do the way I do. So here's my list of references. We'll start out each lecture with a question. Just pause, go through the question, see if you can answer it, and then we'll go through at the end. This helps increase retention. So we'll start out with this ischemia, basically. We're just going to go through terms, mechanism, effects, and outcomes. At the bottom, there'll be a little thing that will talk about where we're at in this process. But I think it's just to talk about some of the very general stuff regarding ischemic heart disease. It's going to be important in understanding it. So remember, hypoxia is basically lack of oxygen, essentially. Ischemia is lack of blood flow. They're not the same thing. So you can obviously become hypoxic without being ischemic. And then ischemia has other problems other than just no delivery of oxygen. There's also no picking up of waste products and not getting rid of carbon dioxide. And then ischemia does not equal infarction. Just because tissue is ischemic doesn't mean it's infarcted. Infarcted is dead. Ischemic means it has no blood flow. It can recover. So skeletal muscle can actually be ischemic for quite some time, for hours, and still survive. And then sometimes you'll hear the term, especially in the brain, it seems like with hypoxic ischemic, and the 2 mechanisms are kind of lumped together. I think it's sometimes because it's just not knowing exactly which one it is in that, but sometimes they are lumped together like that. Okay, so one of my points to ponder: what would cause hypoxia without ischemia? And I'll pause. So one of the things that could cause hypoxia without ischemia is anemia. So with anemia, if you can't carry oxygen as much as you need to, you can pump all the blood you want, but if there's not enough red blood cells to carry the oxygen, an individual is going to become hypoxic. So with myocardium, it's important to think about as far as like when the heart muscle is going to become ischemic. Supply and demand are very important. Obviously, when the heart muscle demands more oxygen, the supply has to keep up. And if you have increased demand but can't increase that supply, then the heart becomes ischemic. And this is very important when talking about the 70-75% stenosis in the coronary artery. That's the point at which you start becoming ischemic with exertion, because you've reached a point where your demand due to the exertion is higher than the coronary artery can supply. So the supply comes from the coronary perfusion, and then the vascular resistance, what allows the blood to get through the vessel. These are all things that are going to play a role, whether there's any compression of it, whether there's local metabolite production that's going to affect the ability of the blood to pass through it, endothelium, what it's producing at the time, and the neural innervation. With oxygen demand, that's based upon this. The demand is and wall stress, the thickness of it, the wall thickness actually, as you see at the bottom, 2H, the wall thickness actually, the greater that increases, it lowers demand. And so this is one reason why the heart will hypertrophy and things like hypertension. And so you can see there, but the pressure, the radius are going to increase the demand. The wall thickness can actually lower it. And also the faster the heart's going, the more it's contracting, the greater is going to be the demand. So basic mechanism of cardiac ischemia, as we just talked about, there's going to be an imbalance between myocardial oxygen supply and the demand. And this could be because you have decreased blood flow through the coronary arteries. If for some reason, for example, the heart needs more blood flow through it and the coronary arteries are vasoconstricted, that's going to decrease blood flow. If there's decreased perfusion pressure, for example, if you have hypotension and you're not able to perfuse at normal level, decreased oxygen content, as I said, anemia, if the person has plenty of blood flowing through the coronary arteries but not enough red blood cells to carry the oxygen, they're going to become hypoxic ischemic. And then marked increase in oxygen demand. If you have the heart that has significantly increased in size or has a significant heart rate or contractility and it needs more oxygen and it can't get it, so there's some imbalance between supply and demand. Also, when we talk about the vascular resistance, we talk about compression. The myocardium can actually constrict the internal myocardial branches, but the good thing is that's during diastole. And then actually it says pressure in the subendocardial region is the highest. This is one reason why you see subendocardial infarcts. That's the first place that it is infarcted, because it has a higher degree of stress and pressure, has a higher demand. So I put this in here as a point to ponder. To the right of it, this is an example of tunneling. So myocardial tunneling or bridging is when the left anterior descending coronary artery passes deep in the myocardium. It has been associated with sudden death in the past and in the current, but it's not generally in most cases considered a legitimate cause of death. Why would that be? So if you pause and we'll go through the answer. So one reason why you think, well, hey, if the coronary artery runs through the myocardium and it compresses, it's going to block blood flow. It's say yes, but if you remember your anatomy and physiology, the blood flows through it during diastole. So when the myocardium is relaxed, that's when the blood is flowing through it. So it doesn't matter if it's compressed during systole, it's when diastole. So there are some times when it does. It depends upon its depth, length, different things like that. But there have been actually symptoms associated with myocardial bridging, but we see it at autopsy quite frequently. So, okay, this is just on the road. This just, I thought was a pretty scenic sunset, sunrise. I think it was a sunset, actually. So with vascular resistance, talking about intrinsic control, one thing that says is the heart basically can't extract more oxygen. It can only increase blood flow to it. So it's basically very efficient at removing the oxygen from the blood that it needs to supply it. So the only thing you can do to get more is increase blood flow. So there's different ways you can do that through vasodilation, and so these are all important things to consider as far as what's going on and why the heart might not be able to receive. So it's not just, like I said, not just from the outside, not just from compression of the coronary arteries or things like that, but also from how intrinsically it's working, how it's vasodilating, how it's vasoconstricting. So what happens is you get switch from aerobic to anaerobic metabolism. And so you get an increased production of metabolic byproducts and everything like that. And these metabolites can actually precipitate dysrhythmias. And then the outcomes of it depends upon the duration and the severity of the ischemia. So obviously if your ischemia occurs in the heart for a minute, you're probably going to be fine. But if it occurs for 25 minutes, you're going to have damage to the myocardium. And then obviously it depends upon, like I said, skeletal muscle can go for apparently several hours of ischemia before it actually has damage to it. So basically, and then too, it depends upon where. If you have a blockage at the beginning of the left anterior descending, that's going to do a lot more damage than one distally and stuff like that. So there's different things that can happen. You can have actually complete recovery from the ischemia. You can actually have infarction also, which is death. And sometimes you can have what's called a prolonged contractile dysfunction. So it didn't die, but it's actually not functioning the way it should, which can make sense. I mean, obviously, when you are ischemic, you're going to change the metabolism of the cell and different things like that, and it could take a while to respond. And that's actually what's called a stunned myocardium. And then if you have prolonged ischemia, you can have contractile dysfunction, what's called a hibernating myocardium. And I actually put something up here. It's not related, but to the right of it, this is what's actually called mummified myocardium. It's actually dead muscle that just becomes mummified in that the progression of the infarct around it goes faster than that. So it actually didn't apply to either one of those. I'm sorry about that, but I just had that picture up there, so I thought I'd add something. So to the question, if you want to pause, then we'll answer it. Okay, so 31-year-old female with a history of heavy menstrual periods presents to her family physician complaining of a pressure-like sensation in her chest. When she exercises, she is trained for a marathon. Laboratory testing reveals a hemoglobin of 9.2 grams per deciliter. Assuming that a cardiac catheterization reveals no obstruction in her coronary artery, what is the mechanism of her chest pain? So the answer would be hypoxia. So if she is training for a marathon, her heart's going to have higher demands, but yet if her hemoglobin is 9.2, and it would be possible to get to a 9.2 hemoglobin if they went relatively slowly to that for whatever reason, and adapted, but now you're really stressing them because of the training for the myocardium, the mechanism would be hypoxia. She has plenty of blood flowing through the coronary artery, so it's not ischemia because there's no obstruction, and so hypoxia. Okay, so once again, at the end, use reflection. Just pause, ask yourself, okay, what are 5 things I learned from the lecture? Like I said, the purpose of this lecture was kind of to touch on some very general topics, just some general ideas. And I think the most important thing is that just concept of supply and demand, that mismatch, what's going to lead to ischemia, what are the effects of it, and that. So, and then this was on the same kind of trip. There's just sunset and everything like that. So a little bit of mountains in the background. This is in Western Montana. So I hope this lecture has been useful. And like I said, there'll be 4 more lectures on more specific details regarding ischemic heart disease. Thank you.